Good afternoon, everybody. Welcome to the Immune Deficiency Foundation Visiting Professor Program. I'm Kathy Antela, Vice President of Education at IDF, and so glad to have you with us today. Just a couple words about the Immune Deficiency Foundation in case you're not familiar with us. The mission of the foundation is to improve the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. Our vision is to ensure that everyone in the U.S. who is affected by a primary immunodeficiency has a fully informed understanding of, first of all, the diagnosis that affects them, all available treatment options, the expected standard of care, and all of their opportunities for connection and support within the PI community. We have multiple programs for individuals with PI and family members of all ages, and we have programs like this one for medical professionals. Bit of information about that. If you do treat patients diagnosed with a primary immunodeficiency, please check out our clinician finder. We would love to make sure that your name and your contact information is in the finder, because one of the main questions IDF receives is, where can I find a doctor? And after today's program, I will follow up with an email with information, links in it, so that you can actually check out each of the opportunities I talk about. IDF for years has been known for its patient surveys. Surveys have been used in research, journal articles, so more patient surveys coming out in 2022. We do have a medical advisory committee and a nurse advisory committee. There is a consulting immunologist program. Any clinician in the United States can get a free consult about primary immunodeficiency from a leading immunologist within 24 hours by using that program. And each year, IDF does offer research grants for clinicians. And right now we are in the midst of a white paper challenge. So with the white paper challenge, there are 3 opportunities to be awarded $10,000 for clinicians who want to address innovative practices to expand awareness in communities of color, methods to increase equity in clinical trials, or novel approaches to shortening the time between diagnosis and treatment. So if you're interested in the white paper challenge, information will also be included in that email about that. And the deadline is February 23rd. At this time, I would like to give a huge thank you to Dr. Kristen Eben and Dr. Beth Thielen at the University of Minnesota Medical School for this opportunity today for everybody to learn about primary immunodeficiencies from a leader in the PI community. So now I turn it over to Dr. Ebens to introduce the session and our presenter.
Thank you so much for that introduction and for sponsoring this opportunity for our group today. We're really thrilled to have Dr. Shan Chandrakasan with us today. For those of you who don't know Shan, he's the Director of Immune Dysregulation and Immune Hematology and Immune Defects Transplant Programs at CHOA, Children's Healthcare of Atlanta, or Emory in Atlanta. His clinical and research interests are focused on the early identification and development of definitive curative strategies for immune dysregulation disorders. His lab works on identifying biomarkers for early identification of primary immune dysregulation disorders. That could be patients with immune cytopenias, very early onset inflammatory bowel disease, hemophagocytic lymphohistiocytosis, using high dimensional immune phenotyping and other next generation technologies. For those of you who do know Shan, you know he's brilliant. He's passionate about his work, his research, his patients. He's friendly. I think Shan knows everyone in the field, or at least all the people I know. He completed his training through medical school in India and then moved to Detroit, Michigan, to the Children's Hospital of Michigan for his pediatric residency with Holly Miller, if you're in our audience today. He then went down to Cincinnati Children's for Hem-Onc fellowship and some additional research time, where he met Manar Abdelghani, who is probably with us today. And now he's at CHOA and has been there, gosh, for maybe 7-ish years, and doing some wonderful work. So he has expertise not only in the topic of discussion today, but also in other areas related to transplantation, including his KO8 funding in non-genotoxic conditioning for stem cell transplant, which we've heard in other settings. So today, Shan will talk to us about the spectrum of immune dysregulation across different subspecialties. He'll highlight his group's work on early identification, management, and monitoring of immune dysregulation in patients with complex immune cytopenia, which for us is quite common and we often struggle with. So it's very interesting to see your approaches, and hyperinflammatory disorders. So Shan, take it away, friend.
Thank you, Kristen, and thank you, Beth and IDF for hosting this lecture. It's been 6 years in Emory, and it has been still a roller coaster ride from the day we started this program. So I'm thrilled to share some of our experiences and research in this field. Again, the field of immune dysregulation is very broad. Even 2 hours of lecture on this will not even touch the tip of the iceberg. So what I thought would have a brief introduction of primary immune regulatory disorders, but focus on the multilinear cytopenias and the another group of fairly common group of conditions that we see in our clinic, post-Rituximab hypogammaglobulinemia, as one of the presenting manifestation underlying PERD. And also touch upon the hyperinflammatory spectrum, where how flow-based direct T-cell activation markers could help in early identification of HLH and HLH-like disease processes. And lastly, we have started picking up some patients with indeterminate acute hepatitis that overlap with HLH. We'll briefly touch upon those patients too. So I realize this is an IDF sponsored lecture. I'm sorry, this is up here, but again, this has helped us. Back in India, we used to see this IDF poster, and it was in Hindi. We could see them in airports posted that if you have these 10 signs, think of immune deficiencies. But one of the big things that was missing is, what about autoimmunity and immune dysregulation? This poster needs an update, and that's even more so in the last 10 years, when with the advent of high throughput sequencing, the breadth of immune dysregulation have expanded dramatically in the last 10 years. And depending on, we all struggle with genetic testing, depending on the resources that is available at hand, you can order whatever type of sequencing you want, single gene to panel to whole exome to whole genome. And the breadth of immune dysregulation disorders have increased from a classical biallelic defect to several defects that are single allele defects with either gain of function mutation, dominant negative, or haploinsufficiencies. And these affect either transcription factors and several immune regulatory pathway genes. And Troy, a few years back, put together this cartoon of different group of genes. This is mainly for the PIDC PIDR study that categorized these defects into different categories. Basically, signaling defects with JAK-STAT pathway, PI3 kinase, all are clustered as a signaling pathway defect, transcription factor or transcriptional regulatory pathways that are defective, and cytokine regulatory pathways. So this is already way too outdated. There are 20 more genes in this pathway, and the number of genetic defects that account for this immune regulatory disorders are more than 100 now. So with this in mind, we always come across patients across different spectrum, right? For this particular presentation, we are going to focus not on the autoinflammatory or not as much on the hyperinflammatory spectrum, but discuss more on the three common spectrums of immune dysregulation that we see. The classical ALPS and ALPS-like, IPEX and IPEX-like spectrum, and CVID. Again, as we all know, a given genetic defect can present across this immune spectrum. The CTLA4 haploinsufficiency could earlier on present like an ALPS-like defect with predominantly immune cytopenias without much of hypogammaglobulinemia infections with significant lymphoproliferation. Or the same CTLA4 could present as predominant enteropathy and endocrinopathy with type 1 diabetes, and these patients get categorized as IPEX-like disorders. And in many of these gene defects, if there is significant association of hypogammaglobulinemia and infections, then they get clustered as CVID-like presentation. So the important thing to recognize is not to get too much into these categories, but at least realize some of us are used to clustering them in one bucket, and these buckets are very fluid. A given patient can start on one end of the spectrum, can progress over time to other ends, and many times they can go on to develop, in addition to CVID, late onset combined immune deficiencies. And one of the ways that how to pick up these patients earlier has been, we have struggled with trying to come up with how do we reach out to different subspecialties to be able to pick up these patients. And again, not all subspecialties are listed, but the common ones that keep referring patients to our group are listed here. They have Hem-Onc group, rheumatology group, GI group, endocrinology. Of late, we are getting significant number of patients from dermatology with refractory eczemas. So the reach out has been very critical, but one of the things they ask is, what type of patients do you want us to refer to your clinic? So in the absence of set guidelines, so internally we have, if we have more than one organ system autoimmune involvement, not explained by a single autoimmune process, like lupus can have multi-organ system involvement. Again, we don't want to end up doing immune regulatory workup for all of them. But outside of known established rheumatological disease, if there is two autoimmune manifestations, then we said we would want to see those type of patients. And if it is very early onset, again, this group of disease has been well established in the IBD cohort, in which infantile onset and very early onset IBD are enriched for underlying immune regulatory disorders. And if they're refractory to therapy, like we have patients who have IBD who have gone through third line and fourth line therapy and also had colectomy and still having refractory inflammatory bowel disease. Those are also the subset that we said we will reach out to. And with or without evidence of lymphoproliferation. So again, this is very skeletal structure, but there is refinement within the hematology group. There is refinement within the rheumatology group. We are now asking for any ANCA-positive vasculitis. If it is atypical, we have asked for screening for ADA. And neurologists are sending patients with SAMD9L from ataxia screening and other things that we are not thought would be coming from. So, the spectrum of these patients from across subspecialties continuing to increase. I think the more broader net you throw in, you're likely to get more early presentations and things that you can intervene early to potentially change the phenotype long term. Again, while discussing the different spectrums, we briefly talked about the ALPS and IPEX-like, CVID, and late onset combined immune deficiencies. One of the interests in our group is immune cytopenias, because one thing is well documented in literature is immune cytopenias can be a presenting manifestation of underlying immune dysregulation that could present across this immune spectrum. They can be just your ALPS or ALPS-like spectrum, or they can present fairly late when they are established late onset combined immune deficiencies. Within our cohort, like about half to 60-70% of our patients come in this spectrum. There are patients who are presenting with underlying CVID-like immune profile with immune cytopenias. But our goal is to see if we pick up patients earlier on in the immune profile in which there is still some B cell function and the T cell function have not worsened. What is the role of identifying these patients earlier on? And intervention started early, does it decrease their progression to a more significant immune deficiency phenotype later on in their disease course? So to switch gears and focus a little bit more on the event syndrome, as we all know, event syndrome is classically associated with when there is autoimmune hemolytic anemia and ITP, either sequentially or simultaneously. Most presentations are simultaneous, but sequential presentations starting out as ITP, 6 months later will be DAD positive and autoimmune hemolytic anemia are also well described. Since the initial description, it has gone on to include even autoimmune neutropenias now. And more broadly, any two lineage involvement nowadays get labeled as either complex cytopenia or event syndrome. And in addition, the presence of obvious hemolysis is not a must. Even if you have a DAT positivity, that's a good enough marker that there is more than one lineage involvement. Majority of the work over the last 10 years have been focused on finding the underlying genetics. As with availability of this next-gen platforms, every specific clinical presentation has been focused on and looked at a genetic level, whether it's very early onset IBD or event syndrome or other autoimmune presentations to find out what percentages of them have underlying monogenic etiology. Couple of years back, the French group published this paper of 80 patients with event syndrome that showed 40% of them had a known underlying immune regulatory pathway defect. And but in the real world, the incidence of finding a monogenic etiology is still, I think, depending on the institution, but when we informally polled few big centers, we were getting incidence of about 20 to 30%. That's still better than what it used to be before, but it's still not anywhere close to having a genetic level understanding for majority of patients with event syndrome. So in the end, majority still end up having a known genetic defect. And from a practicing hematologist, most of them are used to sending ALPS panel. And if the panel goes to Cincinnati, many of them might be familiar with the scoring 1 to 4. Many of them come back as non-diagnostic with a score of 1 or 2. And then if the genetic testing comes back negative, most of it's very hard for a practicing hematologist to know, does this patient really have a broader immune dysregulation? Or we check for ALPS, we check for immune dysregulation. Should we closely follow this patient as any other patient with a gene positive cohort? So within this, we got interested in finding what is the immunobiological underpinning across the board in all event syndrome. Does understanding the immunobiology, irrespective of genetics, help us to understand how to treat this disease better and how to monitor these things better? So those were the questions we had. Again, the main unanswered questions, as I previously told, is though there has been increasing understanding on the genetic basis of event syndrome, the immunobiological understanding is still fairly limited. And another thing that also intrigued us is, despite diverse genetic drivers like STAT1, CTLA4, PI3 kinase delta, majority of patients still respond really well to sirolimus. And within that, we got intrigued in that, are there defining immune aberrations in event syndrome that are common across different genetic drivers? And another question we had is, and there was a nice publication from David Teach's group in 2016, how sirolimus is effective across event syndrome. But in addition to improving event syndrome, what does sirolimus do? Those were the questions that we had in mind. So in order to start this process, we said we need to come up with a catchy phrase for the study. And in addition, we need to start systematically collecting these patients' samples. So over the last 4 years, we have been able to enroll about 25 patients with event syndrome, 24 of them with chronic ITP as a control for single lineage cytopenia. and another 24 healthy controls, age matched. We deliberately excluded patients with lupus and malignancy. And these these patients were enrolled from 3 different institutions, from our own institution, Cincinnati Children's, and Children's Hospital and Clinics in Minnesota. We started out doing a standard workup for all of these patients with immunophenotyping, gene expression analysis on a subset of immune compartment, germline generic testing for all of them. To understand the inflammatory milieu, we did cytokine chemokine profiling. And also to understand the T cell repertoire, we did a V beta repertoire sequencing. Just to know a little bit more about this cohort, we had of this 25 patients, 15 were enrolled at presentation. Another 10 were enrolled during follow-up, but with active disease flares. Majority of them had evidence of obvious lymphoproliferation. And 3 of the patients, in addition to event syndrome, had other manifestations with pulmonary and GI presentation. So one of the striking things we noticed in these patients is a marked expansion of circulating T follicular helper cells. Again, for the audience, a T follicular helper cell is very critical for shaping humoral immune response. It's critical for helping in B cell class switching and affinity maturation. And TFH dysregulation has been discussed in several autoimmune disorders, and also recently by Neil Romber's group in CHOP have reported circulating TFH expansion and activation in a cohort of CVID patients with immune cytopenia. Again, this particular Disney plot shows the expansion of the TFH population. CXCR5 positive memory CD4 cells are considered to be circulating T follicular helper cells. Again, as you can see in patients with event syndrome, there is more of these when compared to healthy control. And these express both PD1 and HLA-DR at much higher percentage when compared to healthy controls. So, so that was one of the striking findings we noticed in all patients with event syndrome, and we did not see it in patients with chronic ITP. And in addition to evidence of expansion, we also saw markers of activation with increase in HLA-DR, and also markers of both exhaustion and senescence with both TIM3 and CD57 expression being increased in patients with event syndrome and compared to chronic ITP.
Shan, can I interrupt for a sec?
Yes, yes.
So you mentioned you don't see that expansion of the T follicular helper cells, in chronic ITP. Do you have any patients who have recovered or are off therapy recovered that you also profiled?
Of chronic ITP or the event?
Who had an immune cytopenia, could be ITP, acute that resolved, or Evans syndrome that's treated and resolved. I know you tell me you treat forever, so I don't know if you would have captured.
Great question. So on event syndrome, there are some patients we recommend treatment because not all patients with, like, they might have platelet count of 50 with positive DAT. Technically, they're relatively asymptomatic. They're not having active bleed. They're not having active ongoing hemolysis. One could argue they don't need treatment, right? So some of those patients have decided not to take sirolimus. When we follow them longitudinally, they still have persistent TFH expansion. Whereas in chronic ITP, once they go into remission, we have sample chronic ITP longitudinally, whether they have gone into remission or they're on TPO agonist and they're not on any immune suppression, but they're on other growth factors that lead to resolution of thrombocytopenia. Their immune profile remains, again, I think when it's a qualified normal immune profile, the more deeper you look, there are going to be immune signatures that are also aberrant in chronic ITP. I'm not telling chronic ITP is a non-immune process, right? It's an immune process, but we don't see this type of immune dysregulation that we see in event syndrome that tend to persist with time. It doesn't go away. Even when we think they're clinically in remission, the profile still remains abnormal.
And is there any correlation with clinical severity?
That's also a great question, but we have fairly limited numbers right now.
Sure.
But while we started treatment, we could see as the cytopenia is improving, as the overall lymphoproliferation is improving, the TFH signatures goes down with time. Again, is it one-to-one effect, or is it it might be more of epiphenomena? We are not sure. So I think that's where further studies, this is just more of a landscape. What is the profile in event syndrome? Each of these needs further detailed studies to see which of this is driver, which of this is more of an epiphenomena that we can use for monitoring.
Thanks.
Thank you. So in addition to this features of expansion, what we see is when you look at a T cell profile, there's naive T cell that is both CXCR7 and CD45RA positive. T cells goes on to have canonically the central memory, then effector memory. And once cells reach to a proliferative senescence type of a phase, they start re-expressing CD45RA and lose the CCR7. And significant proportion of the cells in that TEMRA gate are thought to be in some way senescent cells. They'll have high CD57 expression. So in that compartment, as the T cells mature from naive to go on to a senescent phase, what we see is in the T cells have early acquisition of circulating T follicular helper signature, at least in terms of immunophenotype. And as they mature from naive to a more senescent phenotype, strikingly very high proportion of senescent T cells have the TFH profile, suggesting there is not only early commitment, but there is preferential expansion of CTFH when compared to the rest of the memory compartment. So again, this is an indirect inference that there could be a predominant proliferative stress in the TFH compartment when compared to the rest of the other T cell compartment, or the TFH itself acquires a premature senescent immunophenotype that is unrelated to underlying proliferation. Currently, we are not sure which predominant pathway that's happening, but if we are got to guess based on the transcript and other findings and intracellular Ki67, there is much more proliferative stress in the CTFH compartment compared to the rest of the memory T cell compartment. So as you can see in this graph, in healthy controls, there is hardly any CTFH in naive T cells, CD4 cells. And there is about 5 to 10% of memory cells have TFH signature in healthy controls. And about 5% of the TEMRA have CTFH signature. But when compared that, if you see in event syndrome, you see preferential expansion from naive, there is much more naive having CTFH signature, and it expands even further in the memory compartment. And when you look at the TEMRA, about on a median 30% of them have CTFH signature. So again, we don't see that in chronic ITP, again, suggesting this is something more seen in broader immune dysregulation settings in event syndrome, not with single lineage cytopenias. When we looked at the underlying CTFH repertoire, we could see that as we think there is significant proliferative stress, there is also oligoclonality in that the diversity index are low, Shannon's entropy is also decreased, and the number of clones contributing to about 60% or of the entire clonotypes. Just 50 clones alone contribute to 60% of the entire repertoire in event syndrome and compared to much lower number in healthy controls. Again, suggesting there is likely a proliferative stress, and this is all oligoclonal, and what is driving it is still needs to be addressed. And when we looked at their transcript, what we noticed is a really good validation of what we found in the flow, in that there are several activation markers that are upregulated, and there is several both transcription factor and also checkpoint inhibitors that have gone up. And also there is increase in effector molecules with interferon gamma, granzyme, and transcript for Ki67, suggesting there is significant proliferative stress. And when we compare that with chemokine cytokine profiling, we could see a nice inflammatory milieu in that as you see the increase in interferon gamma, we could also see its chemokine go up with CXCL9 and CXCL10 being upregulated. What was striking is, despite this activation signature in TFH, we didn't really see an increase in soluble CD40 ligand. And that was in the setting of an activated CTFH, not seeing a CD40 ligand and not seeing IL-21 high, basically made it wonder why there is a decrease in certain chemokines and markers of CTFH function decreased, and there is ongoing proliferation activation of the circulating T follicular compartment. This again, we are trying to address the question of, in an expansion of CTFH, why there is decrease in B cell function. If a healthy TFH is supposed to result in more B cell class switching and affinity maturation, why in patients with event syndrome and other immune regulatory disorders, there is decrease in B cell function. So moving away from the CTFH compartment, we also looked at what's going on in the rest of the CD4 compartment. What we noticed is there is overall a decrease in total proportion of naive T cells, CD4 T cells. And the CD4 T cells in the effector memory compartment shows features of chronic T cell activation. Again, the T cell activation in these patients are not super high, but it's consistent, chronic, and low level. Just to give you an idea, in patients with HLH, we expect T cell activations in 40 to 80% in the effector memory compartment. So in these patients, this is about a median of 5% in the CD4 compartment and about 10% in the CD8 compartment, suggesting there is ongoing low-level T cell activation, and this is also validated with when we do soluble IL-2Rs, there is mild increase in soluble IL-2Rs in these patients. Then looking at the B cell compartment, what we notice in these patients is majority of our cohort had normal IgG or IgA levels. I think, as I mentioned here, 63% had normal or increased IgG and 50% had normal or increased IgA. Despite their normal or increased IgA and IgG levels, majority of them had decrease in class switch memory B cells, again suggesting their immunoglobulin profile in many of these patients might be deceptive in that it might suggest their humoral immune compartment is perfectly fine, but many of them, even when they have normal immunoglobulin profile, there is ongoing B cell maturation problems. And this could set them up for hypogammaglobulinemia and more B cell dysfunction down the line. Maybe it's 5, 10, or 20 years. More longitudinal studies will help address those type of questions. I'll skip this. Again, this is just a heat map showing different flow parameters. What you could see is the event syndrome that is marked in the red here is very distinctly different from healthy control and chronic ITP. The chronic ITP and healthy controls, at least on the immune parameters that we assessed, looked overlappingly normal, whereas an event syndrome is distinctly different. And the next question we wanted to ask is, and we had a nice cohort of patients who are gene positive and gene negative within this 25 patients. So we were able to split them and see how does this immune profile look between the gene positive and the gene negative cohort. So when we looked at it, what we noticed is, irrespective of whether we identified a pathogenic gene mutation or not, immunobiologically, they look exactly the same. And their TFH expansion, both the gene positive and gene negative cohort looks the same. The naive fraction look the same, and there is persistent T cell activation in overlappingly same in both the cohorts, and also decrease in class switch memory remains the same. So suggesting the gene negative cohort in at least immunobiologically is very similar to the gene positive cohort. There's likely maybe in next 10 years, there will be 20 more genes that will be associated, and the gene negative cohort will continue to decrease, and it will look, and the immunobiological data will make more and more sense in that they are all the same spectrum. It's just that we might still need to keep looking more. The second thing that we wanted to see is how does the immunoglobulin normal versus immunoglobulin low cohort look? So in terms of the TFH profile and also the chronic T cell activation profile. So what we noticed is, again, whether you have normal immunoglobulin or low immunoglobulins, the CTFH expansion, chronic T cell activation, and naive profile looks exactly the same. The only thing that is different is understandably, the patients with low immunoglobulin profiles have much lower B cell class switch when compared to patients with normal looking immunoglobulin profile. So this is, in some way, this is also could help answer some of the questions, because Neil Romber's group proposed low IgA levels, increased gut permeability, likely drive some endotoxinemia-driven early lineage commitment of TFH. But in our cohort, even with normal IgA profiles, we see the same profile, suggesting there could be even other drivers. One of the classical explanation for CTFH expansion is defect in T follicular regulatory compartment. If these patients have underlying some form of functional Treg problem, then it could also affect the T follicular regulatory compartment. That in turn results in decreased checks on CTFH expansion, leading to unchecked expansion of circulating T follicular helper cells.
There's a question in the chat. Could gene negative cohort have somatic mutations instead of germline mutations?
It's totally possible. Again, in terms of what we had in our panel are all geared towards germline testing. And it's only in the ALPS cohort we have looked at somatic ALPS to sort the double negative and look for somatic ALPS. In the other cohort, at least they were not in frequency that labs reported as a somatic. Again, TLR8 is a hard gene right now in terms of explaining as germline mosaicism could also give immune-driven cytopenias. But it's possible, we have not looked at it, but I would guess the proportion of somatic mutations would be contributing to that cohort would be fairly low. So one of the things that we were hoping to achieve with this study is, can we identify an immune signature that we can quickly ask our clinical lab to set up so that if we say this is a broader immune dysregulation signature, whether it is event syndrome or IBD, can the clinical lab run it and tell us whether there is evidence of broader immune dysregulation or not? Should we treat this patient as a broader dysregulated type of a patient with response to sirolimus when the gene is negative, or should this go through run-of-the-mill what every other subspecialty will treat them as? So within that, we put together all the flow data and tried to run the ROC statistics to find out which immune phenotype could give us additional insight, both in terms of sensitivity and specificity, to pull out the broader immune dysregulation phenotype from a single lineage immune cytopenia like ITP and healthy control. So we noticed 4 of these, again, the CTFH expansion, evidence of chronic T cell activation, decrease in naive, and class switch memory B cells. When we include that and come up with a composite score, most event syndrome would score a median of 3 with range between 2 to 4, whereas both healthy control and chronic ITP would score between 0 to 1. So one of many patients, even with single linear cytopenias, can have a score of 1, either between a transient T cell activation or other abnormality. But it's the persistence of these abnormality and also finding more than one abnormality within these 4 parameters that we found is significant in event syndrome. And the next question we had is, once we identified these are the underlying broader immune dysregulation in all patients with event syndrome, how does treating with sirolimus irrespective of underlying genetics, what does it do to the underlying immune dysregulation? So again, as I briefly mentioned before, David Teach's group have elegantly shown sirolimus across the board in event syndrome. If they tolerate, these patients do well. But the only immune data they submitted in that paper is looking at the absolute lymphocyte count, IgG profile, CD4 and CD8 counts. The focus there was to say sirolimus did not cause additional immune suppression in these patients. But our goal is when we look through our patient cohort, we could exactly replicate the data that addition of sirolimus doesn't make their CD4 counts any different, CD8 counts any different, or the ALC looks exactly the same. But what we noticed is functionally the CTFH compartment could, this is one of our patients, from marked expansion on CTFH, they go back to much more overlapping with normal. Again, this is a median follow-up of 8 months. Some patients were just only on 3 months on sirolimus. Some of them are 2 years on sirolimus. So it's a mixed cohort here. So the data might look more tight if you censor at one time point. But despite the varied follow-up, what we could see is there is a significant decrease in CTFH expansion. In addition to decrease in CTFH frequency, I'm not showing it here, there is also decrease in activation exhaustion phenotype in these CTFH. And the earlier data that we showed that there's preferential expansion of T follicular helper cells with sirolimus therapy, we could see they're all going back to what a chronic ITP or healthy control would look like. So again, early commitment and preferential expansion of CTFH is decreased on sirolimus therapy. And in addition, we could see the features of chronic T cell activation, both on CD4 and CD8 have decreased. What we don't see, again, it's a shorter follow-up, maybe a more longitudinal follow-up for a longer period would give us better answer. We have not seen, even in this limited follow-up, changes in naive T cell frequency or changes in class switch memory B cells. Going back to the T cell data, in addition to decrease in activation, what we saw is a decrease in Th1 signature, whereas with a more coming back to a Th2 type of a profile. And in terms of median scores, from a median score of 3, most of these patients have gone to score of 2 or 1. Again, I want to re-emphasize that this is a shorter follow-up. Maybe a longer follow-up would give even more granular data. But in the absence of any other type of published literature on what does sirolimus do, we thought this would be a good addition. In addition to monitoring improvement in cytopenia and lymphoproliferation, maybe monitoring some of these parameters could give us additional insight. Even at a research-based study, could give us insights of, can this help us if the TFH goes down? Do they not get any other autoimmune manifestation down the line or not? So those are things that are interesting questions for us to answer.
There's another question in the chat from Dr. Abdogani. Is looking at FOXP3 expression in Tregs in these patients helpful from a diagnostic, aside from IPEX and IPEX-like and therapeutic standpoints?
Great question. Again, we did do FOXP3. We have found it to be in less than, I would say, 30% of them, the FOXP3 expression is decreased. But whether there is functional Treg defect or not, it's very difficult. There is not a clinical lab that will do Treg function. There is some thought process that many of them will have varying degree of functional defect. Again, those type of suppression assays are not well standardized, and there are only very few labs in the country that does it really well. And we are looking into a few other markers to see, can we use some intracellular flow cytometry and also post-activation expression of certain checkpoint inhibitors on the surface to look for Treg function. I think in the absence of a very good, robust functional Treg data, I would think the TFH expansion is some way a surrogate to Treg dysfunction. But again, this is just without much data to back up. But I think data on CTLA4 and LRBA deficiency have shown if there is decrease in T follicular regulatory function, the TFH expands. So indirectly, the short answer is majority of these patients have normal Treg frequency, but the functional assessment is still challenging. That's Mana, right? Okay, I was for a second thinking.
Yeah, that was Manar.
Okay. So in terms of future directions, since multilinear cytopenias is one of the early presenting manifestations of immune dysregulation, we really wanted to understand, does early interventions like mTOR inhibitor preserve this T and B cell function? Like if you pick them as an ALPS-like phenotype with normal looking immunoglobulin profile, can we keep them in that compartment for longer? If not for intervention, maybe they might have progressed to have more progressive B cell dysfunction. Again, these are hypothetical, these are hypotheses, right? These are not proven data. So that's why we are planning to do additional follow-up studies, more longitudinal multicenter studies is being planned to answer some of these questions. If we have a cohort of patients who are on this very early on as an ALPS-like phenotype, how long can we preserve that immune function? And does early intervention decrease the incidence of other autoimmune or immune dysregulation manifestations? And another important question for us is, with the advent of this next-gen sequencing, we are able to identify more and more genes. Luckily, we have targeted therapies coming up for many of these pathway abnormalities, but it becomes challenging as this basket gets split with multiple different diseases. How do we still meaningfully able to treat them as a cohort, right? Instead of starting someone on JAK inhibitor, other one on abatacept, how do we still be able to come up with strategies that are semi-targeted like mTOR inhibitors, but still be able to work across the genotype? So like, for example, we have PI3 kinase delta inhibitors and also STAT1, JAK1 specific inhibitors. Can those be used across genotype, not only restricted for just PI3 kinase delta inhibitor gain of function or JAK1 STAT1 gain of function type of patients? So those are the follow-up studies that we have planned. Again, to summarize the immune cytopenia work so far, children with immune syndrome have a broader shared immune abnormality, irrespective of underlying genetic etiology and functional B cell status. The expansion of TFH, low naive CD4 cells, class switch memory B cells, and increase in T cell activation are unique findings that we see in immune syndrome, but not in chronic ITP. These immune abnormalities persist, and a scoring system based on some of these parameters could help both in picking up certain high-risk immune cytopenia patients and also help monitoring the broader immune dysregulation response to treatment in these patients more longitudinally. This particular data set was recently accepted in Blood. I want to give a shout out for our postdoc, Deepak Kumar, who did most of this work. Switching gears from immune cytopenia, we got into this field actually from immune cytopenia work, in that we started getting many of these immune cytopenia patients post-Rituximab, ended up in our clinic with hypogam. And these are hematologists giving ITP and hemolytic anemia patients Rituximab. And 2 years down the line, one of them showed up with osteomyelitis that will never resolve with any treatment, eventually found to be due to mycobacteria, not mycobacteria, mycoplasma. And because it was mycoplasma, there was further immune workup was done and found he was profoundly hypogam. So that got things rolling. We have a huge immune cytopenia cohort that we follow in our institution. So we could easily pull through these patients who got on rituximab and start looking at a little bit more details. So patients with hypogammaglobulinemia following rituximab is usually transient and resolves by 6 to 12 months. And in certain patients, when used as part of chemotherapy, then it might take a little longer. But in majority of them, by 2 years, the B cell number and function more or less returns to normal. In a subset of these patients, again, more globally about 2 to 5%, but if you start looking at high-risk population that gets this, and at what frequency they're giving the rituximab and what doses, then the frequency of persistent post-rituximab hypogam could be higher. Again, these are multiple different published literature. There's a recent Jackie paper by Eli Haddad and Jolan's group. That's a multi-institutional study that looked at some multiple risk factors. Needless to say, this is a real problem as we're using more and more rituximab across both rheumatology, oncology, hematology, and also post-transplant. We are seeing a high number of these patients being referred for immune and genetic evaluation. So broadly, there are two categories. One is a quantitative defect in which they have very low to absent B cells. And the other, there is a qualitative defect in which there is B cells, but they're not maturing to class switch memory B. And in terms of the risk factors in this, again, many of this, all of this are published information. The more rituximab you give, more courses they get. If their immunoglobulin levels are low before treatment, all this leads to increased risk of persistent post-rituximab hypogam. But the interesting question is, what is the driver? What is causing this? Why in majority when they get rituximab, they recover the B cell function? Why in a subset they are not able to? The questions, the not clearly answered questions are whether there is underlying genetic predisposition to underlying CVID or immune regulatory genes that rituximab just unmasks it or just accelerate the process. Or it's still a transient phenomenon, but it takes a longer time to reconstitute. Maybe 2 years is an imaginary cutoff. Maybe we need to put 5 years in it. And the other more pertinent questions we had is, does rituximab really affect early B cell generation in the bone marrow? How does it directly or indirectly affect the maturation capacity of naive B cells? And does it either directly or indirectly affect the T cell health for B cell maturation? So within that, I just want to briefly show a patient, share a clinical history of a patient who had diffuse large B cell lymphoma, got the classical chemo with rituximab at 4 years of age. 3 years after, you're presenting with recurrent sinopulmonary infections and bronchiectasis. CBC was unremarkable, but quickly, because he was presenting with bronchiectasis and recurrent pneumonia, we quickly looked at his immunoglobulin profile. He has hardly any IgG or any IgA, but pre-rituximab, his immunoglobulin profile was perfectly fine. And understandably, he had hardly any vaccine titers. This patient turned out to be an XLP-1, presenting with diffuse large B cell, well-known presentation. But instead of being picked up as a diffuse large B cell lymphoma, he got picked up as a post-rituximab hypogam later. So with examples like this, we put together a study for hypogam, high-risk study to study these patients. Again, it was funded by IDF to look at both biology and genetics of persistent post-rituximab hypogam. And the limited 10 cohort that we have, 10 patients we have currently screened and then genetic workup, we have at least 5 of them have underlying genetic defect. One of them, an extended family, we published this with Sergio recently. It's more than a year now. But again, it's a patient with IKZF1 defect, again, suggesting in a subset of these patients, again, this phenomenon is known. The last few years, there have been papers showing this, the genetic defects of persistent post-rituximab overlaps with CVID and other immune regulatory disorders. But again, this is another group. We should not presume just rituximab. We should go the next step and make sure there are not missed underlying germline defects. But more interesting than this, we see this type of persistent post-rituximab hypogam even post bone marrow transplant. These are patients who are 100% donor reconstituted with healthy donor B cells, and they got rituximab for either post transplant immune dysregulation, like an immune cytopenia, post BMT, or developed PTLD, EBV-driven PTLD, and got rituximab. And we have a very high incidence of these patients go on to develop persistent post-rituximab hypogam. We have some patients that don't have B cells, and within that we got intrigued. Why does the donor, who has exactly the same immune compartment, who makes all the immunoglobulins, now the same immune compartment in the recipient after rituximab exposure is not making any antibodies? So, and in subset, why are they not even making B cells? So within, so in that cohort of patients, we started getting the peripheral CD34 cells, and we set up an assay using mesenchymal stromal cells to differentiate the CD34 cells to B cells. The goal of this experiment is to see whether the stem cells after exposure to rituximab still has the potential to develop B cell or not, whether rituximab directly or indirectly affected the early B cell development potential of the stem cell. So when we did this assay, we could nicely see whether the patients who are both immunoglobulin dependent or independent, both of them develop B cells normally, suggesting there is unlikely to be a stem cell intrinsic problem that rituximab induced that resulted in absence of B cell development. And the second group that we see is a class switch B cell maturation problem, right? Like the CD27 positive IgG negative population don't develop in many patients. So in that cohort, we sorted their naive B cells and gave them the T cell help. And what we noticed is both in the immunoglobulin replacement cohort, that's immunoglobulin dependent, and also in the immunoglobulin independent cohort and controls, their naive B cells could class switch and make surface IgG. And there is no difference between the control and the immunoglobulin dependent arm, suggesting their naive B cells have still the ability, if given the T cell help, will class switch. So again, getting back to the question, if the B cell intrinsically can in vitro differentiate to class switch memory B, why are they not able to do it in vivo? And the next question is, maybe their T cell is not able to give the help. So we took their CD4 compartment and stimulated them in CD3, CD28, and then co-cultured them with naive B cells. When you do this co-culture, we see even the T cell help is there. We don't have answers, but we know they have the potential is there. At least the stem cell intrinsic potential is there. So the conclusions from this study is, again, rituximab use is associated with persistent post-rituximab hypogam. The more you use, the more high frequency it is. Significant proportion of these patients have underlying immune defect. In vitro studies using patient CD34 shows they can make B cells, and there is not an apparent cell intrinsic B cell problem. At least when you do it in vitro, we're able to mature these naive B cells to class switch memory B cells. So more studies need to be done to understand. We're working on a mouse model to understand this problem better. A combination of immune and genetic workup is warranted in most patients to at least rule out whether there is any underlying immune regulatory disorders. In our practice, we have tried to restrict the use of rituximab as much as possible, even in the pre-BMT immune cytopenia world and also the post-BMT. Where are we with time? I just think
we have about half an hour left.
Okay.
So I don't know if you want to kind of take a break there and open to questions or discussion about the initial part of your talk. Since I see you've got
I'm happy
HLH popping up here.
so yeah, this is switching gears. So that's why I wanted to see if there is any questions. I'm happy to answer.
Have you looked at immune cytopenias post-transplant, which obviously are a bit of a different beast with two separate immune systems not getting along well?
Yes. We are done on 2 patients. These are not super common. So fortunately, this is not super common. And post BMT, there is so much immune dysregulation that goes on. And when there is marked T cell activation dysregulation, we don't see much of B cell output in those type of, the profile looks not like this. It looks very different.
Mm-hmm.
But I know many of them do respond to sirolimus even in that cohort too. But I don't want to make any conclusion based on 2 patients. One of the recent patient is a STAT1 gain of function. So again, I don't want to make generalized statement on that, but maybe it's if there is broader interest, we can tag team, and if we have patients.
We actually see quite a bit in our inherited metabolic disorder patients because they kind of have all the risk factors, right? They're getting reduced intensity, they're very young age, often around the age of 1.
And cord blood.
It. So
Yeah, we don't do that much cord blood. So I think that will be a great cohort to study. Like, again, we have additional B cell data that I've not shown, and we are in the process of putting everything together. So it will be interesting to compare that cohort.
Yeah, I agree. Are we seeing any other questions at the moment?
I guess I'm curious if you have thoughts about other, besides Evans syndrome, I find it very interesting that you're able to pull out, using your immune phenotyping, that the gene positive and gene negative groups, phenotypic sort of look the same in immunophenotyping. And I'm wondering if there are other examples of that in other other disorders that we associate with immunology, and whether that holds up in other cases.
So I don't think this is unique for Evans syndrome. What this profile basically shows, any patient with broader immune dysregulation that might have some form of Treg dysfunction might have this type of a phenotype. So we have seen this I've done it on 2 IPEX patients. They look like this. I've done that on 1 CTLA4. There is CTFH expansion. So I think this is more a marker of broader immune dysregulation rather than something specific for Evans syndrome per se. So, like, for example, if you have a cohort of IBD and you do TFH, they're not increased in all the IBDs. I think if this is high, it might suggest you might want to do additional genetic workup. In GI, less than 5 years, there is many big centers would do genetic workup by default, right? For very early onset IBD. What I see interesting is in this older patients who have IBD that has gone to 3rd-line treatment, have some eczema and other autoimmune manifestations. I think it's that cohort, the genetic workup is not done in a very rigorous way. If we have screens, flow screens or other things, maybe genetic testing would be very cheap and it's universally available in the next 5 years. But till we get to that state, I think some form of a screen in a clinical lab that can done just 8 or 10 color flow and quickly check whether they're in the spectrum could help in screening out which ones could be either potentially responding to sirolimus. That's a drug that is not routinely used in IBD management. In addition to which one need further genetic workup. So switching gears to the HLH hyperinflammation group, again, I won't spend too much time on the background. Needless to say, the genetic spectrum of even HLH, what we know as HLH, is broadened a lot, from a bunch of 10 genes that we know that we can rattle out to every gene under the immune regulatory pathway and immune deficiency pathway could be associated with hyperinflammation. And that is nicely shown by this publication from the Baylor group that showed several different immune regulatory hyperinflammatory inflammasome genes can be associated with hyperinflammation overlapping with HLH. So even though the genetics is increasing, when these patients present sick, I know there are a few genetic companies now that can turn around genetic testing in a very short time period, but even that is too long for some of these patients. When they present to us acutely, we might need to make decisions overnight as to how we need to intervene on these patients. One of the challenges is, again, the world is still very married to this HLH 2004 criteria. So how do we make this better, and how do we make well-informed choices based on not just following the criteria, but looking at more specific markers, what means more immune intervention and more immune suppression. So within that, though ferritin is a good marker, but we found, as we all know, it's highly non-specific. And the publication that said more than 10,000 ferritin is still fairly specific for HLH-like etiologies. But we have seen in our practice neonates, when they present with septic shock, and the liver enzymes can go through the roof, their ferritin levels can go more than 100,000. And we have had patients with sickle cell disease who are on chronic transfusion. When they present with hyperhemolytic crisis post-viral infection, they can look like they'll have cytopenia post-parvo, and they'll have massive hemolytic reaction, could look like a HLH. I've seen patients treated as HLH with both dexamethasone and etoposide on neonates who eventually ended up turning out to be just fulminant viremias without any T cell activation, and fulminant sepsis without T cell activation, being referred on etoposide, on dexamethasone. So those things made us wonder, soluble IL-2R is still in many ways a very important test and critical test to figure out whether this other findings you see could be explained by other etiologies, or there really marked T cell activation going on or not. But in most centers, soluble IL-2R is still a send out test. And depending on where you are, you can get it the next day, or it can take several days to get the results. So one of the things we had is what we can do in-house that can give us information about T cell activation within a couple of hours, so that we can make decisions whether immune suppression is the right thing to do. If there's immune suppression, how much we need to jump on. So we have been using markers of direct T cell activation by flow. We use both HLA-DR and CD38 on effector memory T cells to look for markers of activation. Again, with the COVID and the MASC, ICU, every other unit is very sensitized. It gave us a lot of ground to test our flow and see how does it correlate with soluble IL-2 and other inflammatory markers. So again, in the interest of time, I'm just rushing some of these slides through. So this is the correlation plot showing the soluble IL-2R on x-axis and HLA-DR and CD38 and y-axis. So what you could see is when you look at CD4 effector memory and CD8 effector memory activation and correlate them with the soluble IL-2R results, there is a very nice correlation, whether if you look at CD4 compartment or CD8 compartment, you could very consistently pick up patients with marked T cell activation that will come out to have very high soluble IL-2Rs. So this has really helped us not to start immune suppression on patients, like especially neonates, who in every way look like full-blown HLH, but eventually after 48 hours, either turned out to be fulminant HSV without any T cell activation, or bacteremia that presented with multi-organ dysfunction, and ferritin levels were 100,000 with bone marrow suppression. So to avoid immune suppression in those patients, because in neonates especially, we found if we start them on etoposide, they just fall apart. We had patients develop NEC and die. We had patients develop multi-organ dysfunction and die. Till then, they are okay. Once they started on etoposide and dexamethasone, they fell apart and died. So I think it's very important in that cohort in sickle cell cohort and others where there are other reasons to explain why the ferritin could be high, that we need to be very careful what type of interventions we are offering. So within this, we found at least most medium to large centers have access to clinical flow cytometry, either as a part of their diagnostic immunology lab or the hematopathologist. And a simple 8-color flow could give us information, either total T cell activation or CD3 activation within total CD4 and CD8 compartment, or even within the effector memory compartment of CD4 and CD8. So what we see is, as I said, a nice correlation. Usually the CD4 activations tend to be half of what you see in CD8 compartment. And the correlation for both CD4 and CD8 compartments are still very similar. So using this, we could screen several patients quickly within a couple of hours to say who has more on the HLH spectrum of things, who would need much higher immune suppression, versus who we can just start with a moderate dose of steroids and wait and see. And this goes, again, recent Mike Jordan paper that showed more than 7% CD38 HLA-DR positive in CD8 compartment could reliably differentiate HLH from sepsis. But what they didn't show in that paper is how does their data correlate with the soluble IL-2, or that is more established parameter. So what we're hoping to do is to complete our data set of about 120 different time points with paired soluble IL-2 or an HLA-DR, and put together a publication to say this is what the soluble IL-2 correlates are, so that overall there might be more broader use of this activation markers than just waiting on send out soluble IL-2s to come back. Well, we started doing this, we started picking up some patients that look like HLH, but they're not in the HLH spectrum. So one of the cohort is a subset of patients with acute hepatitis. Again, this is a this is a patient that we saw like 2.5 years back who presented with acute hepatitis with ferritin of 900, soluble IL-2 of 6,000 to 7,000. But what was striking in this is this patient is clinically otherwise well, like the liver enzymes were in few thousands, INR was 1.5, but he's running around doing normal stuff. For a HLH-like sick patient, he was not sick. Then when we look through the literature, there's increasing data on this indeterminate pediatric acute liver failure, wherein there's more and more of data that is they are CD8 driven, there's marked T cell activation, polyclonal expansion of the T cells in the liver. And what has been published is steroids in these patients have given mixed results. Even in many institutions, if they look out for features of acute liver failure, if it's not from autoimmune hepatitis, not toxin or metabolic conditions, many centers just wait and watch, either to resolve on their own or they need liver transplant. So within that context, there is currently an ongoing study from the liver group. It's a multi-institutional study supported by NIH that's currently looking at ATG as an option for patients presenting with full-blown liver failure who are checked out negative for toxins, checked out negative for metabolic, checked out negative for other known causes. So in that group, the study is going to look at ATG as a potential treatment option. But what we felt is, instead of looking at the patients at the tail end of burnt out liver, at liver failure, can we pick up these patients presenting as just hepatitis without evolving to liver failure, and see if early interventions, when they're presenting with just mild or moderate hepatitis without acute liver failure, can we prevent them to evolve to an acute liver failure phenotype or not? So just to complete that patient that I previously shown, that patient eventually we ended up treating like HLH, even though he didn't have marked cytopenia, but he fell apart on getting his first dose of etoposide and became pancytopenic. And with bilirubin in 15s, we said we can't give him etoposide or other HLH-like treatment. So we ended up using imipelamab in him with steroids. So he had a very uneven full recovery in that from needing liver transplant, he is now 2 years out of all immune suppressive interventions. And and thriving as a normal child. And his whole exome, workup for primary HLH, everything has been negative. He had since seen several other infections and has not had any problems. So just want to highlight, in addition to the classical HLH manifestations, acute liver failure presentation of HLH is well known, but these patients don't behave like full-blown HLH in that many of them are clinically very stable. They might be even on the floor, but the T cell activation signatures by flow and other ways look overlappingly like HLH. So to study this more systematically, we started following all this indeterminate hepatitis, not full-blown liver failure, but just hepatitis patients with their liver enzymes around few thousands. Even if their INR is just 1.1, 1.2, he said, why wait for them to be full-blown liver failures with INR of 2, 3, and 20 if we can pick up the signatures earlier on. So on 10 patients that we consecutively identified, these patients tend to cluster. 3 or 4 patients come at a group. Again, we think could be post-viral something. We see the soluble IL-2Rs are high, but not like sky high. This is a fold change from upper limit of normal. The ferritin could be all over the place. They might have normal ferritin. You can see some having 20, 107, 179. These are things that if you use ferritin as a screening, whether they have HLH-like disease process, you might miss it, saying this is normal looking ferritin. And the cytopenias are not there. The ANC and platelets might look reassuringly normal. Excuse me. But when you look at the T cells, their T cell activation is not like HLH-like in that they are not super high, but they're not normal either. So they're on a median 50% of their CD8 effector memory is activated, whereas in healthy control, it's usually less than 10%. And the same is true if you use different markers, PD1 and other markers of post-activation exhaustion. They all show the same finding in that the T cells are activated, but it's not like full-blown HLH, but it's somewhere overlapping with full-blown HLH. And you look at different cytokines and chemokines, again, this is acute hepatitis, acute liver failure, and this is HLH cohort, and this is healthy controls. Both of them look overlappingly the same. And in terms of CXCL9 and CXCL10, very similar to what you find in terms of T cell activation profile. They look not full-blown HLH, somewhere in the intermediate. So many of these patients, we don't wait for them to develop a full-blown liver failure. If in the next 48 hours, they're not self-resolving, we have started many of these patients on steroids proactively. And many don't even go on to develop full-blown acute liver failure and they resolve. So again, another example of how you can pick up with simple flow early T cell activation markers that can help in intervening early enough so that we are not talking about interventions that are at a more failure stage, wherein even your best of intervention given late in the disease course may not have the desired effect. So this is another example of how we can, when you pick up early interventions, could decrease the progression to acute liver failure. So just to summarize this part, flow cytometry-based direct evaluation T cell activation markers could help in timely identification of HLH, could avoid unnecessary immune suppressive interventions in critically ill patients without significant T cell activation. A subset of patients with acute hepatitis have marked T cell activation signature that overlap with HLH. And T cell directed therapies or therapies directing the cytokine drivers could still help these patients if started early, instead of using more nuclear options like ATG late in the disease course. I'll stop here, and I would thank again Deepak Kumar and Chengju Prince are the two main pillars of our small lab, and the clinical team that has helped in enrolling many of the cytopenia patients. Carolyn Bennett has been one of the superstars in getting this immune cytopenia patients together. And our collaboration with both Cincinnati Children's and Children's Minnesota with Manar there has sent several samples. Again, I would like to thank the Immune Deficiency Foundation for funding this high-risk study for post-Rituximab hypogam and several other funding sources that helps the lab running. And the clinical team, as you know, it always takes a village for these patients. So I'll pause here And sorry if I run over, but happy to take more questions.
Thanks so much for that really great talk. I guess this is outside my, as an ID person, outside my area of expertise, but I was wondering as you're presenting in interferon gamma about emapalumab and what's been that used. I see that it's been used for HLH, but I'm curious if you can tell us.
Yes, again, the liver patients I showed is actually, this patient actually received, we gave emapalumab for this patient. Again, it's not the magic drug that everyone wanted badly, but it does help in patients who are refractory. And the group of HLH disease I've not shown here, but I think would make a significant impact is there is a group of patients who develop this T-cell EBV HLH, in which the HLH is driven by EBV in the T and NK cell compartment. There's a case report by Mike Jordan's group that showed emapalumab alone as single drug has helped patients like that. We have used that in that context in 2 patients and found really good results. And I think these are patients where you want to immune preserve their T cells as much as possible, but taking out some of the chronic, maybe interferon gamma, when it's very high, it can also cause immune paralysis. By blocking it, in that context, it helps in actually helping in controlling the T cell activation from the EBV that is uncontrolled in the T cell compartment. So currently, we try to use it in patients. The label is only for refractory patients and patients who are intolerant to etoposide. But in our practice, we use it for almost all neonates when they present with a primary HLH or HLH that looks like a primary HLH. We have very low threshold of using emapalumab, mainly because that's the age group we find they don't tolerate chemo well. Whether you want to show it as give it a dose and say they fall apart and then do it, we have convinced our institution enough that we don't need to do that. That these are patients, maybe if we can start steroids and emapalumab upfront, it might be a better option for more long-term. And many of these patients still end up needing etoposide, but not at the doses that is listed in the HLH 2004. You can space out to every 2 weeks at much lower doses. So those have helped to decrease exposure to etoposide.
Looks like there's another question from Manar again. Could you please share your experience with the treatment of autoimmune cytopenias in the context of hypogammaglobulinemia, not on immunoglobulin replacement therapy? Do you use sirolimus in these patients too?
Yes, and that's, yeah, we use sirolimus in that patients too. But what is interesting is when you wipe out B cells with rituximab, the TFH profile looks very different. And there is TB interaction that goes on at the lymph node level. And when the B cells are wiped out, the TFH frequency dramatically falls. And it takes a long time to build back up. But irrespective of that, there is still this chronic low-level T cell activation we can pick up. We may not be able to pick up the TFH expansion. So whether it is in the CVID context, there is complex cytopenia, sirolimus still helps majority of those patients. Or in the context of post-rituximab, but the events is still ongoing, sirolimus still helps many of those patients. We almost use that as after steroids, the next go-to, and then see if there are specific genes, like if it's a STAT1 or if it is a CTLA4, what else you can add on later. So sirolimus comes in upfront.
Thank you.
Well, Shan, thank you so much for your time and expertise. We really appreciate it. And I'm sure we'll have more questions coming to our minds after we leave, which I hope you'll welcome, as you always welcome my emails with questions. But thank you. It's been terrific.
Thank you so much. And thank you, IDF. Thank you, both Kristen and Beth and Manar. And we look forward to more continued collaborations like this. So this field there's a lot more to be uncovered. I'll follow up on the post-BMT immune cytopenia. I think that's open field there too.
Yeah, we'd love that. That'd be terrific.
Thank
There's
you.
some other comments coming in from Tampozo saying fantastic talk and thank you. So more friends at Children's, and also say a welcome to our colleagues from NICER who joined us today as well. So a lot of
Awesome.
a lot of
Thank you.
overlap of ideas.
Thank you so much, Shan.
Thank you. Thank you. Thank you, Manar. Thank you, everyone.
Amazing. Thank you.
And thank
right.
you from the Immune Deficiency Foundation to everyone who attended today, to Dr. Chandrakasan, to Dr. Evans, and to Dr. Thielen. Amazing. Thanks so much.